Thank you very much. My name is Jeff Wang. I'm a spine surgeon from Los Angeles, California. I also, in my other role, I'm the incoming president of the North American Spine Society, and I just want to congratulate all the organizers of the society and this meeting. I think I speak for the entire organization of NASS and the entire board of directors, many of whom are here today, in saying that we feel honored to be a part of this. We're happy to be here, and when we look at many of the international societies that we collaborate with, we see many different societies, but the way you are building your society and building your organization, I have to congratulate you. I think you're doing it all in the right way, and we feel that you will have a huge impact now and in the future. It's my honor to talk about cervical approaches for sagittal deformity. These are my disclosures. I'd like to talk about three areas. I think we all see patients with cervical disorders and cervical deformities, and I think the goals of the surgery, whether you do it anteriorly or posteriorly or whatever your approach, are all the same. The goals will be to help the patient. We want to decrease their pain, we want to decrease their symptoms, but we also are thinking now, looking at the literature for scoliosis surgery and thinking a little bit further down the line in the sense that we not just want to correct the problem today, but we want to think about future problems that that patient may have. How many times have we seen a patient that has a problem anywhere in the spine and then they need a surgery down the line years later? And I think if we look at the alignment, that's one of the things that we can control with the initial surgery and possibly decrease the need for surgeries in the future. I think when looking at cervical deformity, we want to make sure that the patient is looking forward. We want to decompress the spinal cord if there's any compression. And we really want to establish the normal cervical alignment, not only looking at them from the front, but I think more importantly, in the sagittal plane, looking at them from the side. Now, I think there's been a little bit more awareness of sagittal balance, at least in the thoracolumbar spine for scoliosis, and that's being sort of translated into the cervical spine. And we know now that looking at the cervical sagittal axis from C2 to C7 actually is very important. And we know that the normal distance is about 1.5 centimeters. And when patients get a sagittal axis where they lean forward and there's imbalance and it's greater than 4 centimeters, we know that they can have significant disability. The important thing also when we're approaching these patients, we need to understand where the normal lordosis and the normal alignment is. I can tell you, and this is something that I think people know about, but where is most of the lordosis of the cervical spine? The vast majority of the lordosis is really at C1, C2. Now, most of us don't think about sagittal alignment. We don't think about lordosis at C1, C2. We're always thinking about where the pathology is the most common, C5, 6, C6, 7. Those are the vast majority of at least the degenerative disease that we're treating. And when you look at from C4 to C7, that's only 15% of the normal cervical lordosis. And so it's not that important about the total amount of lordosis, but it is important to make sure the patient's in balance. But you have to really assess that patient, because if you are operating at C5, 6 and C6, 7, where there's normally not that much lordosis, and you give the patient too much lordosis, you can actually see a compensatory kyphosis in the upper cervical spine. And so we have to think about it, because the upper cervical spine is a little bit different than the lower cervical spine. But we know the cervical sagittal vertebral axis has an effect on the patient's outcome. We know that the patients who have that abnormal sagittal vertebral axis in the cervical spine, they won't do as well. When you look at their outcome, you look at their health-related quality of life, basically if you have a larger C2 SVA, you're going to have a poorer outcome. And so we need to try and establish that. I think we're all familiar with the lumbar spine and the pelvic parameters in the lumbar spine, the pelvic incidence, the sacral slope, and things like that. And in the cervical spine, I think some of the measurements that we look at are really sort of the T1 slope, the thoracic inlet angle. Now, unfortunately, a lot of times on the radiographs, you're not able to measure these. So it's hard to measure the thoracic inlet angle, especially if they have big shoulders and you can't image it. But the thoracic inlet angle is the one fixed parameter. It's like pelvic incidence in the pelvic area. The neck tilt and the sacral slope actually should equal the thoracic inlet angle. I think a lot of people are focusing on the T1 slope as a measurement of whether the patient needs more lordosis or the patient has a problem with balance. We look at, if you look at the literature, there's a million different things you can measure. I kind of focus mainly on the sagittal vertebral axis as well as the T1 slope. And if we think of the T1 slope, much like the pelvic incidence, on the diagram on the left, the patient has a very large T1 slope, and you can imagine to put their head into balance, they have to have a larger amount of lordosis, whereas the diagram on the right, the T1 slope is not that large, and so the patient does not need that much lordosis to keep their head balanced C2 over C7. And so this is sort of a very similar rendering of this. You have a small thoracic inlet angle, a small T1 slope. You don't need a lot of lordosis to keep yourself in balance, but the opposite is also true, that if you have a large T1 slope, you have a large thoracic inlet angle, you're going to need more lordosis. The other thing to understand is the T1 slope is variable. And so if they have a T1 slope greater than about 30 degrees, then you should probably image the entire spine, because there's probably something going on down low, maybe in a thoracic and lumbar spine, that's maybe making them compensate in the cervical spine. The second thing I want to talk about is the approach. Now, if we're making a decision on how to approach these patients, whether we're going to do it anteriorly, whether we're going to do it posteriorly, how we're going to make a decision, I think there's several factors. I think we have to take into account the normal alignment of the cervical spine and understand how that relates to the thoracic and lumbar spine. This is an example of a patient with a primary cervical deformity, and this is a patient that actually has a primary deformity in the thoracic and lumbar spine, and they're trying to compensate by hyperlordosing their cervical spine. And I think it's important to evaluate that to understand, is this patient imbalanced because of a primary cervical problem or because of a problem they're compensating? And this is an example of a patient that their pelvic parameters are kind of off. And when you look at the sagittal vertebral axis, the diagram on the left, and you look at the C2 to C7, they're way off. The SVA is much too large and they're off balance. But if you look at the middle column, middle picture, you can see that the C7 plumb line is actually posterior to the pelvis. So this patient is compensating with their thoracic and lumbar spine for a primary cervical deformity. And to operate in the thoracic and lumbar spine would be a mistake. In this patient, you fix this primary cervical deformity and you can put the patient back into balance. And this is an example of that. This is a patient that I saw. This is a female who had a history of neck pain, previous surgeries, both in the cervical and the lumbar spine. And when you look at her balance, when she presented, and actually she presented to me later, but these were images that I saw that she brought in, you can see that she has a primary cervical deformity because her C7 plumb line is actually posterior to the pelvis. And so the mistake here would be to try and get more lordosis in the thoracic and lumbar spine and not address the cervical deformity. And when you look at the sagittal vertebral axis from C2 to C7, it's much too large. This patient has imbalance in the cervical spine. And this patient, actually, if you can look at the diagram on the left, the surgeon who managed this did a lumbar surgery, trying to get more lordosis in the lumbar spine, and the patient couldn't compensate. So actually, by fusing the lower lumbar spine, he took away the ability to compensate in the cervical spine for the primary cervical deformity, and this patient actually fell forward and even has a worse problem in the cervical spine. And so this patient we had to do an osteotomy for to correct the primary cervical deformity. In general, when I approach these patients, I try to understand a few things. Is it a focal problem or is it a global problem? Is it just a primary deformity of the cervical spine, or does it compensating? Is it related to the rest of the spine? Is it rigid or is it flexible? Does a patient have significant myelopathy as they do? In general, I avoid anterior standalone constructs. Multi-level posterior surgeries are the primary way to treat these patients that have severe deformity. The other problem is if they have really severe deformity, you may not be able to access the front. And this is an example of a patient where they have a sort of a chin-on-chest deformity. If they have a chin-on-chest deformity, then you can't really get into the front, so you really need to manage these patients from the back. In this patient, you can see on the left, that's how they presented. There's no way to access the front. We admitted the patient, put them in traction. We actually got them somewhat corrected just by traction in the hospital. And this allowed, you can see the x-ray on the right, there's more space in the anterior spine. So we were able to go in the front, at least initially, decompress the spinal cord, get more alignment, and restore a little bit of the cervical sagittal vertebral axis, and then we backed it up from the back. But if you can access the front, you can do an osteotomy in the front, even if they have posterior cervical fixation. You can do that, but you have to resect the facet joints, so you have to do a wide, you have to protect the vertebral arteries, You have to resect way out so you can release the anterior spine. And then you can put, depending on their bone quality, you can even use dual Caspar distractors. And this is an example of doing an osteotomy from the front. Basically, you resect everything out laterally. You can see there are two Caspar pins at each level to give more force. And then you don't want to distract on those pins, so you distract with an interlaminar spreader, and you can see yourself getting a lot of correction in the front. And then you can put a loose graft in the front, and then you can go ahead and get more correction in the back. And then you can use the head as a lever. And this is, a lot of people feel uncomfortable with this, but you have a really long lever arm. You can push on the head as you're doing the correction, so you don't stress the bone quality of the Caspar pins, and you can get a bit of a correction there, and then you can go in the back. And this is an example of a patient had a cervical deformity. It was hard, but all this correction was done from the front, and then you can lock them in from the back. The last thing I want to talk about is that these patients can have a high rate of complications, just like the thoracic and lumbar deformity surgeries we do. You can have greater neck pain, but if you restore their alignment, we know that they're going to have better outcomes. This is an example on the left side where they had a fusion and they still were able to compensate and they're in good alignment. You want to try to avoid this situation on the right. But it has been shown in the current literature that patients will do better if you restore their cervical alignment. If you think about doing laminoplasties, the patients who are not in good sagittal vertebral axis will not do as well, and they have more spondylolisthesis, and that correlates with a higher T1 slope. And then the adjacent segment disease, which we're all concerned about. Will they break down at the adjacent segment? And if you can try to restore that normal alignment, then you probably, hopefully, may prevent at least the rate of the development of adjacent segment disease. These patients can have high complications. We warn them about the potential for complications. The neurological risks are very high, and you have to talk with them about wound issues, problem swallowing. One of my other roles is that I'm actually the current president of the Cervical Spine Research Society, and I was one of the guest speakers at the European meeting, which is our sister society this year, and they have a multi-center prospective study looking at cervical deformity and look at the complication rate, 43% postoperative complications. And so if you're going to do these surgeries, you do have to counsel these patients. But the vast majority of these patients, at least with severe deformities, you have to treat from the back. You have to make sure you set them up appropriately. You can put they're in deformity, so you put the table, the highest rung on the head and lowest there, and then you can do a wide resection. And this is just an example of us doing an osteotomy. I believe it was at C7. We release the spinal cord, make sure there's no impingement of the dura. And then it's important to have a good team so that once you're ready to do the correction, and I try to do these with my partners, here you can see we're putting temporary fixation rods in, we're making sure the spinal cord is completely decompressed, and then perhaps the most important part of this is to make sure that we can, and this is the correction part. So you can see we're looking in the wound and we're loosening the temporary rods. One of my partners is then going to break out of scrub and go down and realign the head. And you want to pre-plan this so as you're correcting the spine, one of us is holding the head there, you can see on the left, and one of my partners is down below releasing the frame, and now we're able to correct the deformity, and we can observe this and make sure that there's no buckling of the spinal cord. Here we're tightening provisionally to make sure that there's no subluxation. I think these temporary rods kind of help you as far as helping it from subluxating and creating problems during the correction. And then you can adjust things a little bit later, try to get a little bit more correction, a little bit in the sagittal plane and the coronal plane. But we typically do these together. I think that shows the effect of having good teamwork, not only with anesthesia, but with your own surgical team. And that's sort of the corrected deformity there. I'm sorry, I don't have really good post-op pictures, but we locked them in and tried to restore their alignment. And here's the intraoperative x-ray showing that we've corrected this deformity significantly and gotten rid of the chin-on-chest deformity. So in summary, I think there's an increased awareness of the cervical alignment, and I think that just like the thoracic and lumbar spine, if the patient has an abnormal alignment in the cervical spine, we have to try and correct that. Thank you very much.